That the department is here now, and welcome to all the panelists. Good afternoon and welcome to this Health and Government Operations Committee briefing. We're joined today by members of the Senate Finance Committee as well as the House Appropriations Committee. This is a virtual committee briefing, so I ask for your patience if we encounter any technical or streaming issues. This briefing is being streamed on the Maryland General Assembly's YouTube channel. Committee members will be muted throughout the briefing. If you have questions after the presentation, please use the raise hand function, which is located either underneath your participant list on the right side of your screen or under the reactions bar at the bottom of the screen. I'll call on legislators to ask questions. After I recognize you, please wait a moment while Melissa unmutes your screen. Remember, even though we're meeting on Zoom, please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each individual panelist. Also, please keep your questions shorter than the expected answers. Today, we will hear from the Maryland Department of Health on 3 related topics with additional feedback from stakeholders. Legislators have been approached repeatedly by stakeholders regarding actions taken by the Department of Health when the governor ended several emergency orders. A common theme among providers was the reliance on assurances from the department related to reimbursement that were not honored. Legislators considered these ongoing concerns from healthcare providers important enough to schedule this emergency briefing, and there were people in other committees who were interested because they too had been contacted, so we have included them. First, we'll hear about Medicaid and changes to the administrative day rate reimbursement for adult daycare. Second, we'll hear about Medicaid reimbursement for behavioral health services delivered via telehealth. Last, we'll be briefed on Medicaid Appendix K changes related to the Developmental Disabilities Administration. After each brief, we will hear comments from stakeholders. Then we'll hear limited questions from committee members. Please keep in mind the briefing is scheduled to conclude by 4 p.m. I recognize Delegate Kelly to provide context on the issue of adult daycare.
Thank you, Madam Chairman, and thank you all for being here today. So the issue we're going to hear about first is the medical adult daycare program. This is a program that serves some of our most in need Marylanders, those who are Medicaid eligible, nursing home care eligible, and receiving services that are home and community based. The adult medical daycare programs were closed at the beginning of the COVID pandemic in March of 2020, and they were allowed to reopen again in March of 2021, but they have not yet fully reopened. In fact, only 60% of these programs have reopened, and I believe they have seen an attendance at about 40% their pre-COVID rate among those programs that have reopened. The challenge that I am hearing about most is that during the time that the centers were closed, they were promised an administrative rate similar to what we did with childcare programs to make sure that these services, that there was continuity of services for these individuals after the pandemic. That administrative rate was committed to continue through September 30th of this year. And then in July, the story was changed and the administrative rate was now, they were notified it would be cut off on August 15th. I want to see these programs up and running as much as the next person. I think they're incredibly important, but I am also very interested in hearing from the panelists today about what we're doing to make sure they are getting up and running and able to support themselves without the administrative rate before August 15th or after August 15th, as the case may be, from the panelists, because we need these programs to provide services for our citizens in a safe and effective way.
Chair, you might need to unmute yourself.
Thank you. I'm a little rusty again. We'll now, thank you, Delegate Kelly. We'll now hear from Deputy Secretary Yee from the department.
Good afternoon, Madam Chair. Can you hear me?
Yes, clearly. Thank you.
Thank you. Madam Chair, or Chair Pendergrass, excuse me, Chair Kelly, Vice Chairs Penny Melnick, and Vice Chair Feldman, members of the two committees. My name is Webster Yee, Assistant Secretary at the Maryland Department of Health. With me today, I'm also joined by Dr. Leah Jones, Deputy Secretary of the Behavioral Health Administration, for a topic a little bit later. Just, I think, to summarize a little bit and to recap what the Chair said, Maryland's COVID-19 state of emergency and catastrophic health emergency, pursuant to the Governor's constitutional statutory authority under the Public Safety article, was declared initially on March 5th, 2020. On March 12th, 2020, the state issued the first of the large gathering at facilities and facility closing orders, which included the closure of senior centers. This was followed on March the 16th of 2020 with a Healthcare Matters executive order that closed all medical adult daycare centers as of March 17th, 2020, and it also authorized various emergency measures to ensure that the state would have enough healthcare providers at our COVID-19 alternative care sites, hospitals, and nursing homes. On August 1st, 2020, the state issued a revised telehealth order that replaced the March 20th telehealth order, and it allowed Medicaid to reimburse for audio-only telehealth and generally permitted healthcare providers to deliver telehealth services through audio-only calls or conversations. At the same time, the federal government issued an advisory that the U.S. Department of Health and Human Services Office of Civil Rights would suspend its enforcement of HIPAA-compliant telehealth systems and the Centers for Medicare and Medicaid Services, or CMS, permitted Medicaid and Medicare reimbursement for certain audio-only telehealth services. The state took proactive steps to issue guidance to its providers in March of 2020 in conformance with the above policy directives. I'll discuss these steps in more detail in a moment. As in late December 2020, Maryland began its successful COVID-19 vaccination efforts, and it is now nationally recognized and ranked as, by most metrics, the sixth best state in the union in terms of vaccine administrations. As of today, 78.1% of all Marylanders 18 and up have received at least one dose. 93.4% of all Marylanders 65 and older have received at least one dose. And critically, 88.1% of all 65 and older Marylanders are fully vaccinated, and 58.8% of all Marylanders 12 to 17 have received at least one dose. In June of 2021, all of our deaths from COVID-19 were from unvaccinated individuals. As of July 30th, or as of today, excuse me, there have been a little bit over 3,000 post-vaccination infections out of more than 3.3 million Marylanders who are fully vaccinated. So with these positive vaccination rates, the governor was able to announce in June that the COVID-19 state of emergency was ending. As part of those announcements, July 1st marked the beginning of an administrative 45-day grace period by which state agencies would complete the administrative transition out of the pandemic. This is the unwinding that we are currently in the midst of. I should note that we consult with our clinical colleagues on a daily, if not hourly basis, and we are constantly taking the steps appropriate to ensure that we review COVID-19 flexibilities and make adjustments based on clinical need, administrative efficiency, and authority as delegated or directed by the General Assembly. And I would note that the governor had a press conference yesterday where we announced a requirement for all staff at our state's congregate living facilities for them to be vaccinated with at least the first shot by September 1st or face weekly testing and masking requirements. With respect to adult daycare, the state closed all adult daycare facilities on March 17th. In a coordinated provider transmittal on March 16th, the Department of Health announced that medical adult providers were required to offer certain services to their Medicaid participants and were thus able to bill an administrative day rate of approximately 85% of the in-person day rate, or about $88.95 in exchange for a daily check-in phone call with those individuals. On Tuesday, March the 9th of this year, the governor reopened adult medical daycare facilities and here's two of the nuances, to existing clients enrolled in care on or before March 14th of 2020. These facilities were allowed to reopen effective Friday, March the 12th. Adult medical daycare providers had the option at that point to either, one, deliver services in person to fully vaccinated individuals, or two, continue to provide certain services, the daily check-in call telephonically to the individuals whom they had provided care up to then. New clients were allowed to enroll on May 1st, 2021. This also allowed a client who had been with one provider to transfer to another provider. And as part of the reopening process, the health department worked with adult daycare providers to prioritize COVID-19 vaccines and also to make vaccine available to both staff and clients who had not been able to receive the vaccine. As of next week, at the end of the administrative grace periods, all remaining restrictions on these providers end, and at that point, that also includes the administrative day rate. To be very clear, at this point, we believe that adult medical daycare providers should provide in-person services, especially to this population that especially needs in-person services. And we encourage both their staff and any interested patient to get a vaccine as quickly as possible. Open to questions, Madam Chair.
Thank you, Mr. Assistant Secretary. We will now turn to the panel that is here with their concerns. Dana Kaufman, will you start and then each person go in order?
Can you hear me okay?
Perfect, thank you.
Thank you, Chair Pendergrass. And good afternoon, respective chairs, members of the committee. For the record, my name is Dana Kaufman. I'm with the law firm of Schwartz, Metz & Wise, and I'm here today on behalf of the Maryland Association of Adult Day Services. With me today is two owner-operators, Afshin Abedi and Karen Lakin. We appreciate the opportunity to come before you and talk about what impact the discontinuation of the administrative rate will have on the industry. And I also want to applaud Delegate Kelly for her very good synopsis of what this means. And it's very simple. It will cripple the industry. I don't typically mince my words, so I'm not doing it now. We have been extremely appreciative of that administrative rate that has been given during the mandated closure. It has been a lifeline. Without it, centers would close, or would have closed, I should say. But discontinuing it on August 15th prematurely, again, as was stated previously, that rate in April was promised to be paid through September 30th, and it was part of the reopening plans. But what we have seen and what Mr. Abedi will be talking about is that being able to open and being able to operate successfully are two different things. And our centers have seen both such a dramatic decrease in census. At the same time, we are also dealing with operational challenges, which include a staff shortage. It's interesting to me because the department continues to talk about vaccinations. And I applaud the state and everyone who has gotten a vaccine. But the vaccine is not keeping centers from opening. What is keeping centers from opening, and Delegate Kelly was correct, about 60% have opened, but they've opened with decreased census. What has kept operators from being able to fully open is fear, basically. We have rising cases right now. We have a Delta variant. And as was stated previously, nursing home eligible is the key to being able to participate in medical adult day, which means that these individuals who attend medical adult day are the state's most vulnerable and medically challenged individuals, which also means they are the most threatened by COVID. So I'm going to turn it over now to Mr. Abedi, but I think what I would like to say in closing is we have spent a year trying to stabilize this industry and make sure that when this pandemic ends, this vital community service is available to your constituents. And to literally pull the rug out right now before this pandemic is over seems very short-sighted. We need help, we need assistance, and we are asking for the administrative rate to continue until the industry is stabilized. So thank you very much.
Good afternoon. Thank you very much, Dana. Chairman Pendergrass, honorable members of the committee and the department, thank you for the opportunity to testify today on behalf of Maryland Association of Adult Day Services. My name is Afshin Abedi, and I'm the immediate past president of the association, where I served as the president for the past 5 years. Medical day care industry is facing multiple storms at the present time. These storms are strong enough that on a good day, just one of them would have caused major issues for the industry. Unfortunately, at the present time, being hit by all of them at the same time has created a perfect storm condition that the industry has never been subjected to, and that without you all's help and continuation of the admin rate, many medical daycares will not be able to withstand. I would like to share the results of our recent survey of the industry, where we compared pre-COVID enrollments and attendance with the present values. If I can have the first slide, please. Appreciate it. Thank you so much. The first page is going to show a graph. Thank you very much. In this graph, the green area in the background represents the size of the centers, the center license capacity, with the largest centers being on the left and the smallest ones on the right. You can see it has a very, shows all kinds of medical daycares across the scan. About 43 out of the 122 medical daycares participated in this survey within 5 days of business survey call, just to show the urgency. The blue line in this graph represents the pre-COVID average daily attendance for the centers. The red line shows the current average daily attendance. And as you can see, virtually all facilities are showing a major reduction in in-facility attendance at the present time, resulting in about 60% census gap across the industry compared to pre-COVID era. Clearly, you would agree that no medical daycare can operate with 50 or 60% reduction in revenue. Unfortunately, this is what's going to happen if the admin fee is stopped. Now, we will explore a bit more about the causes of this gap in the next slide, but before we leave, and also how long we think it's going to last. But I'd like to bring your attention to one more factor. Looking back at the red line again, you can see that there are many facilities with zero attendance. This is because these facilities, despite being allowed to open since March, haven't been able to open yet. At the present time, as was mentioned, about 63% of medical daycares have opened. Next slide, please. Thank you. The biggest square encompassing all the rectangles here represents 100% of pre-COVID enrollments. So basically all the people who a facility had. The column on the left will represent 30% enrollment loss. 30% enrollment loss just to begin. This is due to the fact that during the state of emergency, medical daycares were not allowed to accept new participants into the program. And the survey shows that about 11% of participants have passed away. About 20% have been basically discharged to out of the medical daycare program, most likely to nursing homes or other 24/7 care options, which are much more expensive. But just by itself, this is a major issue, one of those storms. By itself, this would represent about 21% loss in revenue just to begin just one problem. Let me bring the additional issues to your attention. In the lower right-hand side, you can see the red region. It shows about 6% of enrollments have not returned to the in-facility services because of vaccination issues, but nearly 30% are hesitant to attend due to fear and other issues they have, and that's exacerbated with the Delta variant. So with such significant reductions in enrollment and hesitancy and fear in the participant pool, medical daycares are most likely not going to be open be able to get close to their normal operations for many months. Most medical daycares we surveyed, they feel that it's going to take them at least a year, if not more, to do so. And clearly, they can't operate at 50% reduction in revenue for such a long period of time. Also, from this data, it's clear that the department is using the wrong metric for justifying their position. Percent vaccination is clearly not the big picture. So the metric that needs to be used in here has to represent the whole thing. And it seems like the best metric for using for here to show all the complexities associated with the problem is percent attendance compared to pre-COVID. For example, once the percent attendance reaches 85 or 90%, then it makes sense to reduce the admin fee. And one final point is that continuing the admin rate doesn't carry a fiscal note. That doesn't require any additional budget. At this point, I'm going to turn it over to Karen Lakin to discuss additional reopening challenges. And thank you very much for your time.
Thank you, Afshin. And I'd also like to thank everybody for the opportunity to testify today. My name is Karen Lakin, and I'm a small provider here in Maryland and have been for over 30 years. And I wanted to talk to you a little bit more in depth about some of the operational challenges that we are dealing with. Certainly initially vaccination, which is required at this moment, was a challenge. But as vaccine became available, that quickly became one of the lesser issues for us to deal with. On the bigger notes, one of the things we're realizing is that the workload of bringing all of these very frail individuals back to our centers has been extensive. They've been gone for over a year. And as you can imagine, an older person or a person with severe health conditions can change a lot during that time. Our nurses have had to do in-person assessments to reevaluate every single person. We've had to obtain new physician's orders, do new care plans, and put completely new plans in place for the operations of our clients. We requested from the department early on an extension in those timelines because we are bound by pretty significant regulations in COMAR. We asked just to have a little bit of extra time for this initial assessment and paperwork, and we were denied that. We were told we had to be within the bounds of the COMAR regulations. So our nurses have been working like crazy to try to do all of these evaluations and get these clients in. As you can imagine, that is extremely labor intensive, given particularly that most centers have one, maybe two nurses. So there's not a lot of people that can do this. So that has tremendously slowed down our ability to bring our clients back. So that is one of the reasons that we've had low census. The other thing that we're all dealing with now post-pandemic is this hiring crisis. Many staff have not come back. And so we are trying to find new employees to replace them. One of my small centers alone has a brand new management team now, a new director, a new nurse, a new activities director, a new front desk person, and only me to do the training for all of those individuals. I am not unique and I am not alone. Many of us are working short-staffed, just like all of the other industries around the state. But given the kind of work we do, it makes a tremendous difference on the number of people that we can accommodate and care for safely every single day. So that's been a big issue. We've been doing a lot of education with family in regards to things like infection control and the safety at our centers, but the emergence of this Delta variant now has certainly increased the hesitancy even further for those clients that have not returned at this time. Many of them took a wait and see approach. They were scared to let their vulnerable loved one come back into a group environment, which is very understandable. And that was despite the fact that everybody was vaccinated. With the Delta variant now, these folks are digging in deep. They're scared. And so they want to wait a little bit longer. And again, it is very understandable. In addition to that, while the governor has allowed us as of August 15th to accept unvaccinated people, I will tell you, we are now scared to do that. We have a safe environment at our centers because all of the participants are vaccinated. And by the way, we have very high employee vaccination as well. Not 100%, but we're working on it. And to open those doors now and to allow unvaccinated folks in and risk an outbreak that then jeopardizes everything we've done is terrifying. So I know, for example, my centers will not be allowing unvaccinated staff in at this time. We just can't take the risk. That setback would be enough to close us permanently. So the result of these things is that we have a much lower census, as the graph that Afshin showed demonstrated. And that is not just because of vaccination. Matter of fact, vaccination now is not the reason. It's because of these other challenges. Our expenses are rising as well. I spent my entire morning trying to find a new health insurance plan that I can afford to offer my staff. And I will tell you, it's a bit emotional as a result. It's terrifying. So the expenses are going up as well. And not just with things like insurance, the employees that are coming in are all demanding that higher wage. And then we had some significant unexpected challenges. I don't know if you've heard about the crisis we have in Maryland with the thefts of catalytic converters off of buses and vehicles, but it's a big deal. And what's happening is that we've had many centers that have come in the morning and wanted to transport clients in, only to find that their catalytic converters have been stolen off of their buses. We've been sharing the word. We've been working on increasing our security. We got lucky. We heard about it. We moved. We got 2 of our buses moved, and the next morning, the 3rd bus had the catalytic converter stolen. But the adult day center down the street from us had 10 catalytic converters stolen, every single bus, which completely paralyzed them until they were able to get them fixed at about $3,500 a piece. So, those are just those additional things that really don't even have anything to do with the pandemic. They have to do with real world challenges. But this is why we only have about 60% of our centers open. And it is why we're begging, actually at this point, for an extension. We're asking you to just honor what you told us initially, which all of us took to heart in our budgeting and planning, and to continue. We don't want to hand out. We just want that continued hand up. We are here to serve the seniors and the disabled adults in Maryland, but in order to continue to do that, we just need a little extra time. So thank you for your consideration. We really appreciate it.
Thank you to that panel. I'm now going to go to questions from members. I don't see any hands raised. It may be that I'm looking at the wrong oh, there's a hand. Okay, I'm looking at the right panel. We'll start with Delegate Kelly.
Thank you, Madam Chairman, and thank you to the panel. I have so many questions, but I will keep it brief, and I will direct just one question, one answer, as is our HGO policy. So while I'm very curious to hear from Mr. Abadi about what might happen after August 15th cutoff, I will direct my question to Webster Yee, because I'm hoping he can predict this a little bit, because I would imagine the department has been thinking about this. So my question to Mr. Yee is, what do you expect is going to happen after originally these organizations were planning for a September 30th administrative rate ending September 30th. Now they've been told it's going to end abruptly on August 15th. Right now we've got 37% of them or so that are not open at all, and the other 63% that are operating well below capacity. So what is your expectation for this industry after August 15th? How do you expect them to manage to both stay open and, in the case of those that haven't been opened yet, get open? And most importantly, what is the department doing to help facilitate that? Have you looked at some sort of hybrid model that might both encourage centers to open and incentivize them to stay open by offering some modified administrative rate? Has there been any creative thinking or response to their very detailed letter expressing their very specific concerns other than the vaccination requirement?
Certainly, Delegate Kelly, thank you for that very good question. To answer your question, the department is looking at all of our metrics, COVID-19, provider, et cetera, on a daily basis, and we intend to make adjustments as necessary. With respect to the roughly 40 providers that have not reopened, we intend to work with them over the next couple of weeks, next couple of months to see what are the impediments to reopening. And as we work with each provider, we'll go from there. And that's the basics in a nutshell. Virtually everyone in Maryland has been affected by COVID-19. And at this point, we can only encourage everyone to get vaccinated, because that's the best way that we can end this pandemic as quickly as possible.
Madam Chair, may I have a brief follow-up?
You may.
Thank you. So I absolutely 100% on board with the get vaccinated. I really appreciated Ms. Larkin's comment about the fact that after August 15th, the fact that vaccinations will no longer be required is not going to be of help to her center because she intends to continue requiring vaccinations. I certainly think that's probably very important for many consumers. So again, I would come back to sort of has there been any specific thought of either continuing the administrative rate through the committed September 30th date or meeting with them to modify the administrative rate in a way that is, where you're really paying attention to how they can keep their businesses open so we can increase the number of in-person services that are offered, which is, I think, everyone's goal.
The short answer is yes. We are looking into it. And again, we're going to work with the providers that haven't reopened to figure out what are the impediments to reopening. And so we intend to take a look and see what's on the table and what can be done.
So your intention is to not leave these centers that are open and doing the right thing, but struggling financially high and dry with no administrative rate. You're willing to work with them in some way to ensure that they can keep their doors open because they're providing such incredibly important services?
We're always willing to work with providers. And I think that's been our mantra for the past couple of years. We look forward to having conversations with some of the providers. So the answer overall is yes.
Great. Let me let other folks ask their questions. Thank you.
Yeah. And let me say that I am giving priority to the members who are responsible for the area of legislation that this is. So in this case, Delegate Kelly got extra time. I will limit questions from other members to one with one answer, but the person who is most responsible needs to follow up. Next on my list is Senator Bidle.
Thank you, Madam Chair. Thank you, Deputy Secretary, for your comments. I guess I'm confused. I need some clarity. So the letter comes out that the administrative fee is going to stop on August 15th, but your comments are saying that you're going to work with the providers. And then my concern is that with the Delta variant, that their attendance, the participation in these programs is even going to go lower as people become more afraid to be out in public, vaccinated or not. So is that part of your consideration that the Delta variant is changing the landscape? And how are you going to work with the providers when the letter has already come out that their fees are being cut?
Well, with the lawyer in me basically would give a lawyerly answer, Madam Senator, and that's we're looking at the totality of the circumstances right now. We're trying to figure out what's the best balance between what's legal, the administrative grace period ending, and how do we ensure that we have a strong provider community. And so at this point, the situation is as I outlined, but we hope to work with the providers and really focus on the ones who haven't reopened.
Mr. Assistant Secretary, when was it that you announced the change to this rule?
The governor made the announcement on ending the state of emergency on June 15th, and we work with the providers, we work with the Medicaid unit to make the announcement at the end of June.
So at the end of June, you told the daycare centers that you would be changing the rates from what you had already planned to pay them, and they heard you commit to. Is that correct?
That's correct.
And today is the middle of, it's not the middle of August, it's only the 6th. Is that correct?
Today is August 6th.
How many meetings have you had with providers since
We have not had any
the
yet, but we
announcement was
intend
made?
to have some.
What?
We have not had any yet, but we intend to have some soon.
And how many days do they have that the rules are being continued at the rates they were expecting?
Approximately a week.
So how many meetings do you intend to have in this next week to come to some solution to keep these establishments open so that people who need these services get the services they need and they're not in nursing homes costing about 10 times or 100 times as much?
Again, Madam Chair, we intend to work with the providers who have not submitted reopening plans.
I don't think that's an answer. I think the answer needs to be, how many meetings are you going to have? When are you going to have them? Are you going to have daily meetings for the next 7 days with providers, any who want to communicate with you?
Thank you for your advice, Madam Chair. We'll take that into consideration.
That was a question. It wasn't advice. My advice is never listened to, so I'm just asking a question. Is the answer yes, we'll be doing that, or we will think about it?
Madam Chair, we're going to focus on working with the providers who have not reopened or have submitted reopening plans.
My concern is that if you do that, while you're doing that, you'll have other providers caused to go out of business and close, and then you'll have to start all over with those providers. I think that this needs to be done in a way that you're reaching out to more people more quickly, since we have 7 days. And since you've had 0 meetings so far. Okay, I'm going to call on Delegate Johnson.
Thank you, Madam Chair. My question is there a possibility to go back to the original promise, September 30th, while you have meetings with all providers, not just the ones who have not been able to open up? Because this will affect all providers.
Again, Delegate Johnson, pursuant to the end of the state of emergency, the administrative grace period is ending next week. We intend to work with the providers who have not reopened and to see what are the impediments towards their reopening.
I'm going to turn to Senator Kelly for the next question, since she is the chair.
Yeah. Mr. Assistant Secretary, I appreciate everything you've explained and that you have some levity to do other than what you announced. But I'm really concerned about the impact of the current Delta variant on everybody, whether they have attempted to follow your new orders or they have been able to do anything at this particular point. All of them are, this is really staff heavy by nature of what the service is. And everybody's impacted. And then we're hearing about the catalytic converters being stolen, so people can't do the transportation. The hesitancy is real, but we saw earlier from your own slides that we've got deaths that are impacting the census, that we've got people that are now in nursing homes at a higher cost impacting the census. And I'm just wondering, could the department, in light of circumstances that you couldn't have imagined and we couldn't have imagined, neither could these providers, with this Delta variant being so out of control, to at least consider some interim grace period so that all providers could get more help and you could be more aware of what they in every case is having to deal with. That's really my question.
And Madam Chair, that as always is one of the most astute questions I think I've heard, and I've heard many over the past day, past week, past months. The unwinding of COVID-19 flexibilities is immensely complicated. We're having numerous conversations with other state agencies, as well as members of the Budget and Tax and Appropriations Committees. And the question about, what can we do financially and what can we do programmatically is certainly out there. We hope to be able to work through adjustments based on the COVID-19 situation, but at least at the present time, we are following the end of the administrative grace period.
I'll now turn to Delegate Hill.
Thank you, Madam Chair, and thank you everyone on the panel for presenting. Mr. Assistant or Deputy Secretary, could you, since what I hear you saying is that you're going to work with the ones who haven't opened, you're not planning on working with the ones that have opened, and are saying that when you take the administrative fee away, you're essentially going to kick the leg out from under this 3-leg stool they're standing on. So what I would like to know is if the state has been reimbursed by the feds for the money that we put forward initially for the administrative fees through Relief and CARES Act, and the money to continued administration fee continues to come from the feds. Why? What is the logic that has the administration making a decision to not only not extend the administration fee given the current circumstances, but not even to honor the original agreement or the original offer? What is the logic behind that?
At the end of the day, Delegate Hill, the basic objective is to safely reopen providers to the maximum extent possible and to allow participants to receive the in-person services that they need. We are, as I've noted before, working with other state agencies, and we hope to make adjustments as we're able to.
I'm not allowed to follow.
Yeah, there's not a lot of answer there, but we will now move to Delegate Krebs.
Thank you, Madam Chair. This is a challenging issue. My question, I'm going to sort of change gears and talk about the families and the caregivers and the patients. So we've been 15 months with 16 months. What have people been doing with the patients that need this care? You said they were all nursing home eligible. I mean, and if we were to interview the families, what would they say? What obstacles and what have they been doing and what will they do if they don't have a place to have their loved ones looked after?
Madam Chair, I'm assuming that question is directed to me and not to the
Well,
association.
yes, you can answer it, Mr. Assistant Secretary, but I'm maybe one of the caregiver, one of the centers might want to give it. I mean, I'm looking at the families. We're trying to give Medicaid services to people that I would think have extreme need. They're not in nursing homes, but what's happening to those folks and what will happen?
Delegate Krebs, who would you like to answer that question? Would you like it to be a provider or would you like it to be the secretary?
Maybe the secretary could answer what your focus is and how do we address the family needs, caregiver needs?
Very briefly, we've heard from constituents that they would like the return of as much in-person services as possible.
Did that answer your question?
Yes, but one little quick follow-up. You said that there's no new entrants are not allowed to come in and other people are sort of phasing out for one reason or another. What is a person in this period of time in the future? How does a new entrant even get care?
Providers were allowed to take new patients, new fully vaccinated patients on May 1st, Delegate Krebs. And then on August 15th, there are no restrictions at that point.
But those people are just getting this phone call. I mean, they're not necessarily getting the care.
Providers had the option of just offering just a daily check-in phone call, or since March, they've had the opportunity to take in fully vaccinated residents or participants, excuse me.
All right, thank you.
Okay.
I just want to focus on the families a little.
Thank you, Delegate Krebs. We'll now turn to Delegate Bagnall.
Thank you, Madam Chair. Deputy Secretary, given that we have full approval for the vaccine imminent, we're looking at early September, recommendations for the boosters and a plan for that early September, and that you identified September 1st as the deadline for providers to get their first vaccination, which would mean that they would be fully protected. We're looking at middle of October if they're getting the two-shot vaccine. That September 30th date feels very relevant and strategic. So my question to you, given that all of these barriers are existing for not just getting, full capacity, but also that these facilities are still experiencing significant staffing issues. Do you have a dedicated team that is going to be working with these facilities over the next 7 days? And how many members of that team do you have? Because I think it may be an unreasonable expectation for these facilities to be proactive and for the department to be reactive.
Delegate Bagnall, that's a very astute question. To answer your question right now, the answer is this is coming out of my colleagues and my sleep cycle. So it's extra duties as assigned, and we're trying to do the best we can in terms of reaching out to providers as part of the COVID-19 unwinding. With respect to your comment on dates, it strikes me that my colleagues and I in the Department of Health back in April and March thought that September 30th was potentially a good date. However, thanks to Marylanders being more eager to get vaccinated and our declining and still low COVID-19 numbers back in June and July, and even now, we were able to end the state of emergency far earlier than expected.
I'm next going to call on Delegate Saab.
Thank you, Madam Chairman. Mr. Deputy, you're doing a great job being a lawyer. You haven't really answered a lot of the questions, but I guess one of the main concern is how much of a priority is the department giving to this specific issue where a lot of those businesses have planned their financials and the way to deliver their services based on what they were promised. And I understand there's this, within the next 7 days that this will go away. I guess the question is, or the ask is there a way to extend the original agreement and then go back to the drawing table and have the meeting? Because frankly, I don't think 7 days is going to be enough time to come up with a solution to the issue. So it's more of an ask, and whose decision would it be, the final decision to reinstate what was promised?
Delegate Saab, the final decision would be the health secretary. And to give you an idea of the priority of the adult medical daycare center providers, they were one of the first that we closed. They were one of the last to be reopened. They are, the last to fully reopen. And we've provided a lot of bandwidth and resources towards ensuring that these folks could safely reopen.
So sorry, just to follow up, so could you ask him if he would consider at least to extend it until the issue is resolved? And we would appreciate it. Thank you, Madam Chairman.
I'll absolutely pass the message along, sir.
Yes, it's nice to have you passing messages on instead of the person who can answer the question. I'll next call on Senator Hayes, excuse me.
Thank you, Madam Chair. Once a delegate, always a delegate.
That's right.
With HGO, my former colleagues there. Webster, I wanted to go a different direction around like local control, and hopefully you can help educate me. I know the governor has made public statements that he's not going to do any statewide mandates around masks, and obviously, and pretty much leave it up to the local jurisdictions. Depending on the jurisdictions, they've been making separate decisions about masks. None of them have made decisions around closures. But I guess given, the governor's really kind of firm statement about leaving it up to each local jurisdiction and not willing to deviate from that, if it comes a time where local governments are making decisions absent a statewide mandate, which in your experience have the providers have been beholden to? I know that they're licensed by the state, but they reside in these local jurisdictions. I'm just trying to get a clear understanding of, because I could imagine being a provider, how confusing it may be without like clear instructions that are consistent across the state.
With this provider category, most of their, but not all of their participants are Medicaid eligible. And then the facility itself is licensed by a separate part of the department, the Office of Healthcare Quality. So to answer, I think, your question, should a local jurisdiction go into lockdown or close specific facilities, I think that would certainly necessitate a very deep look, and if not a rethinking of certain factors and circumstances then.
Okay, I see 5 more hands up. I'm going to say at this rate, we'll be here until 6 o'clock tonight. So if you can not ask your question, please save your question for one of the other panels. If you have great interest in that, try to pick and choose, and we'll try to get through this as quickly as we can, and we'll stay till we're done. Delegate Cullison.
Thank you, Madam Chairman. I do not understand the rationale, Mr. Assistant Secretary, so I'm just going to ask it outright. Was there a belief on the part of the department that by stopping this administrative fee, it would force these businesses to open before they, without any kind of transition period? Was that the belief? Is that why you did it?
Delegate Cullison, I can emphatically say that we are committed to the safe reopening of all of our providers, and we look forward to working with the specific daycare providers to find out how we can help them. What are the impediments towards reopening?
Okay. Still,
do you want to follow up, Delegate Cullison?
I think that's
maybe to say, could you please answer my question?
Right. If you can just tell me whether or not it was the intention of the rule to force these businesses to open.
No.
Then what was the reason?
Again, as I've noted, the administrative grace period is ending next week, and with the removal of legal authority and basically going outside of the catastrophic health emergency, we are effectively going back to pre-COVID-19 situations and authorities at the health department.
But there was a guarantee of funding up until September 30th. Why is it ending 6 weeks early?
The Department of Health's prediction back in March was unfortunately incorrect. Marylanders stepped up and got vaccinated faster than we were expecting, which is a good thing. And we were able to end the state of emergency sooner than expected.
Okay. Thank you, Madam Chairman.
Thank you, Delegate. Delegate Sample Hughes.
Thank you, Madam Chair. This hearing that we have today is truly, again, disheartening. And I say that again because I've had personal issues with the Maryland Department of Health and have seen even more so how inefficient and ineffective it is. So that is directed directly to our Assistant Secretary. The question is, what is the estimated cost to ending service, or excuse me, the level of funding at August the 15th to September the 30th? What savings are you anticipating receiving, Mr. Secretary?
Madam Speaker Pro Tem, I do not have those figures readily at hand. I'll certainly take a note to myself and get back to you.
I hope you do, because I think the bottom line is that it is about money and not about the genuine love and care for our senior citizens in the state of Maryland. Thank you, Madam Chair.
Thank you. Senator Benson, you get the last bite at the apple.
Yes, thank you very much, Madam Chair. Mr. Deputy Secretary, let me get back to August the 15th for the unvaccinated requirement. What are the federal guidelines for the unvaccinated going into the daycare? Is that a federal guideline? What is the federal government's position on this?
To my knowledge, the federal government has not issued any specific guidelines, either prohibiting or encouraging or anything. It's, I think, just left to an individual's judgment call.
Have you all given consideration as to what happens if we open the door for unvaccinated individuals? Have you given consideration as to what could happen with these daycare? With the daycare?
Yes, yes, Senator Benson.
You know, the Deputy Secretary, I think I can speak for most of us. We're just troubled by the response that we're getting this afternoon relative to the questions that we're asking. Thank you, Madam Chair.
Thank you very much. We will now turn to the subject of Medicaid reimbursement for behavioral health teleservices. I will call on Subcommittee Chair Cullison to lay out the context, please.
Thank you, Madam Chairman, and thank you all for being here today. You know, over the last 10 years or so, the General Assembly has passed a number of bills with respect to telehealth, but the utilization was fairly low until the pandemic hit. Of course, that's when most of visits to providers had to be virtual in many cases. And it was through the agreement from carriers, providers, and client and patients, we said we would treat telemedicine in the same way that we treated in-person visits. As we're transitioning out of the worst of the pandemic, and we're not out of it yet, in the 2021 session, we realized that there were lots of questions about the efficacy of telehealth for all medical services, including behavioral health, and questions about appropriate reimbursement rates. After a number of sponsor meetings with the parties prior to the 2021 session, and 5 insurance and pharmaceutical subcommittee meetings during session about this issue, we came to consensus. Those of us, the advocates and the members of the committees came to consensus that, and these were including members, representatives of MDH and Medicaid, that we didn't have enough data and information to make informed policy about the appropriate use and reimbursement rates for telehealth. MDH was always aware of these meetings, attended some of them. Medicaid attended at least one of the subcommittee meetings. The bill, which is now law, explicitly applies to both commercial carriers and Medicaid. No one from MDH or Medicaid raised any concerns that the bill was requiring something that was not appropriate. And the committee, the entire MGA, believed that we were in agreement with the spirit of the bill. We passed HB3 and SB3, Preserve Telehealth Access Bill, unanimously in both chambers, and it was signed by the governor on April 13th. This law assigned MHCC to gather information over the next year to report to the MGA, and in the meantime, keep all, and I emphasize the word all, services and reimbursements in place as they existed under the emergency orders until June of 2023. It is anticipated that in the 2023 session, the MGA will have the information it needs to make good policy. We're here today because it seems that MDH and Medicaid leaders have made a unilateral decision, not based in data or known outcomes, about when telehealth is appropriate for those individuals in residential behavioral health and mental health settings and psychiatric rehab programs. This decision is likely to have short and long-term negative impacts on the accessibility of mental health services. If we lose one provider because of this decision, then the state of Maryland's services are declining. We want to learn today in this hearing what the basis for this decision is and ask for your reconsideration of these guidelines while the study is in progress. And with that, Madam Chairman, I turn it back over to you.
Thank you, Chairman Cullison. We will hear from Webster Yee, followed by Dr. Aaliyah Jones.
Thank you, Madam Chair. And if it's easier for the committees, please, everyone just call me Webster, since that's, I think, what everyone does. Just to let you all know, I'm happy to be in the doghouse. My wife's already put me there. I'm missing our wedding anniversary for this briefing, so it's not a big deal. Going to behavioral health telehealth reimbursement, Webster Yee on behalf of the Maryland Department of Health. The governor's telehealth executive order ended on July 1st, and Senate Bill 3, House Bill 123 took effect on July 1st, 2021. At that point, any flexibilities that were not encompassed in statute but were permitted in the executive order expired. One example of this is the controlled dangerous substance prescribing exception. As of July 1st, providers are now required to follow pre-COVID-19 statutory requirements for the prescription of opioids and other controlled dangerous substances. The governor's executive order allowed that, for example. As part of the department's internal review and unwinding of COVID-19 flexibilities, the state's clinical staff fully reviewed the behavioral health services under the public behavioral health system and adjusted a very small number of the services that they believed and that they recommended were not clinically advisable to be provided through telehealth due to the nature of the service or the manner by which the service is provided. As the legislature permitted in Senate Bill 3, House Bill 123, Medicaid is expressly permitted to define eligible provider types for telehealth services. During the week of July 12th, the department issued provider transmittals of the telehealth service changes that will take effect at the end of next week with the expiration of the COVID-19 administrative grace period. I should note that our Office of the Attorney General and I think the General Assembly's Office of the General Assembly have been discussing this topic. At this moment, our Office of the Attorney General believes that the department's guidance does not violate Section 5 of Chapter 71, Senate Bill 3. The department has no comment on any scope of practice discussions that are currently ongoing. We remain focused on reimbursable services permitted to the relevant licensed behavioral health provider and on ensuring that Marylanders get the in-person services they need so that we can respond to help those suffering the opioid epidemic. And if I could trouble the committee staff to put up a PowerPoint and go to slide 3, I've got 2 slides that will illustrate the categories of service. Thank you. The first slide are the general categories of service that continue with a telehealth component. And as you can see here, these are categories, but there's many what are called service codes. So I'm not going to go through them in detail, but I would like to say that this covers, we believe, the vast majority of services that are provided for behavioral health services. And again, the transmittals are available at the bottom of the page. And then if I could go to the next slide, please. These are the ineligible services, and we believe that there are 4 of them. The first is psychiatric rehab program on-site services. The second are residential substance use disorder services, and 50% of those services can be provided through telehealth. The remainder are in-person requirements. And the basic premise here are if someone's getting only telehealth services for residential services, then outpatient substance use disorder services may be more clinically appropriate in that case. The next category, ASAM 2.1, returns to pre-COVID-19. Again, because our clinical colleagues believe that at least 2 hours of in-person services are necessary, and with respite services, that they return back to pre-COVID-19 requirements. My colleague, Dr. Aaliyah Jones of our Behavioral Health Administration, is available to answer questions on additional clinical questions, and I'm happy to take questions as well. Madam Chair, I think you're on mute.
Yes, thank you. We'll turn to Ann Seacott now and your panel.
Thank you, Madam Chair. Good afternoon, everyone. My name is Ann Seacott, and I'm with Public Policy Partners. I'm here today on behalf of several clients, the Maryland Addictions Directors Council, the Maryland Association for the Treatment of Opioid Dependence, and the Maryland chapter of the National Council on Alcoholism and Drug Dependence. On behalf of these organizations, I want to thank the legislature for passing the Preserve Telehealth Act. We've all learned a great deal in a tremendously short amount of time about this service delivery method, not service, but service delivery method during the last year and a half. We are also appreciative of the governor's public health orders that over the last year and a half have significantly expanded its use during this just unrelenting pandemic. My clients all weighed in support of the Preserve Telehealth Act, and they believe that the law requires the continuation of the allowance of the use of telehealth for the next 2 years while the outcomes and other data are analyzed. We do not agree with the Behavioral Health Administration and Medicaid that its use should be limited in residential treatment settings. You'll hear why from the next witness. We have to acknowledge that just because a public health emergency is lifted, it doesn't mean the public health threat is gone. When the population of people being served in treatment programs is more likely than not unvaccinated, when the workforce that had already experiencing a shortage issue includes those with young children at home who cannot be vaccinated, and when the news about the Delta variant gets scarier and more serious every day, we have to err on the side of public health safety. Add to that the increasing number of overdose deaths, and we are facing a time where we should have access to services as open and available as possible. We hope to engage in clinical discussions with MDH as the year goes on. The program directors and clinicians who are currently in the field, who have been dealing with the public health safety issues with regard to both their clients and their staff for the last year and a half, have a great deal of experience in all aspects of clinical care right now. We continue to offer this expertise in what we hope will become an ongoing dialogue with policymakers in the department. I'd like to turn it over now to Kim Weirman.
Hello, I'm Kim Weirman, representing Maryland Addictions Directors Council. MATSI is a provider association representing 1,000 residential treatment beds, as well as a full continuum of outpatient behavioral health care across the state. Thank you for this opportunity to testify today in support of HB 123 with unrestricted telehealth use for all levels of care, including residential, which was allowed under the state of emergency. We also strongly support the client's right to choose telehealth versus face-to-face services, which is also required by HB 123. The need to continue this unrestricted use of telehealth is essential to reduce the spread of COVID among our clients who were overwhelmingly homeless and unvaccinated. But most importantly, providers need every tool to save the lives in the face of the opioid overdose crisis. With the fentanyl epidemic, lethality has soared and residential clients come to treatment in tremendous need. Approximately 1,000 people a year for the last 3 years have died of opiate overdose in Baltimore City alone. Most of these deaths due to the fentanyl overdose. Telehealth allows us to make the plethora of services needed for these residential clients rapidly, flexibly, and effectively available. The crisis services, medical and psychiatric services, rehabilitative and social services marshaled to stabilize these high-intensity residential clients occurs face-to-face at the unit and with telehealth, creating the best, most rapid service delivery for the client. The treatment community continues to serve as a therapeutic agent, while rehabilitative services, medical and psychiatric, employment counseling, housing searches are brought right to the client in the treatment unit. Our actual experience over the last 15 months using telehealth in treatment leads MATSI to conclude this is a tremendous benefit to clients. MATSI surveyed clients during the pandemic to gain feedback on telehealth services. A survey in June 2020 of 439 clients across the state and all levels of care was followed by a survey of residential clients in February 2021. Both surveys document overwhelmingly positive responses ranging from 87% to 92% in support of telehealth for both group and individual services. Overall, BHA recently reported a 31% vaccination rate for public health clients. Residential clients arrive homeless and unvaccinated to treatment. A 50% telehealth allowance weekly, or 3.5 days, does not assist providers with managing a 10 to 14-day quarantine for COVID. However, the 50% restriction does place an additional administrative burden on providers. The current claim system does not allow for tracking daily hours of telehealth versus in-person services. This means providers must track the daily split of hours for every client, creating additional significant administrative work. Lastly, MATC does not understand the clinical rationale for restricting low-intensity residential clients who require 5 hours of treatment per week as per ASAM, who are re-entering the community, working full-time, and re-engaging in life to a 50% telehealth restriction, while clients in more intensive outpatient levels of treatment, some 20 to 42 hours a week, who may also be in state-funded beds, are allowed unrestricted telehealth. Why don't the clients working toward independence, engaged in full-time work and in other life tasks to serve the same flexibility as outpatient clients performing those same life tasks? In conclusion, MATC strongly supports the unrestricted use of telehealth as a service delivery method. It was allowed under the public health emergency, and we believe it's required under the Preserve the Telehealth Act. We also are strongly in support of client choice. Thank you very much.
Thank you, Madam Chair. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland. And with me today is Heidi Kendall, who's the Director of Adult Rehabilitation Services for Shepherd Pratt Health Systems. We respectfully believe this prohibition on reimbursement of PRP groups, that's psychiatric rehab program groups, rendered via telehealth is ill-advised and ill-timed. PRP was designed as a group activity for those with the most serious mental illnesses in the community. It teaches community living skills and provides socialization opportunities. When COVID hit, our providers shifted from in-person groups to telehealth groups and made significant investments to do so. The department's guidance allows for reimbursement for one-on-one PRP services rendered via telehealth, but not group services. There are a few reasons we hope the department will reconsider this decision. One is that the recovery from the pandemic is not consistent for all populations. Despite our best efforts and others, the individuals served in the public behavioral health system still hover around 30% in that range for vaccination rates. And at the same time, the research is clear that those with serious mental illness are more likely to contract COVID than the general population. Many of our clients are understandably fearful of coming back into facilities, but they still need the support of staff and they need the interaction with their peers. The department's rationale around the prohibition is that PRP is expected to combat social isolation, and we totally agree. But having a one-on-one with a staff person is not nearly as effective as a virtual interaction with staff and peers. Ironically, outpatient clinics will still be continuing to offer group services and reimburse for same via telehealth. It's just the PRP groups that are prohibited for reimbursement. A second consideration should be our workforce shortage. We were in a crisis mode prior to the pandemic. It has only gotten worse since then. Moving from a group model to a one-on-one model will be difficult, if not impossible. We simply don't have the staff, and we don't see that changing in the near future. The rest of healthcare is moving toward this hybrid model so that clients, patients can decide the modality. Do they want to come in person or do they want to get their service via telehealth? We think those same options should be available to people with serious mental illness. And I think that was really the intent behind HB 123. And it's going to be interesting to see how we can study the effects of telehealth per that legislation when it's already prohibited for certain types of services. And finally, I would note in closing that we're using the same technology right now for this interactive briefing to discuss why we shouldn't be using this technology for a PRP group. I don't understand why it's interactive enough for our purposes and for the legislature's purposes, but not for purposes of running a rehab group. So we respectfully urge the department to reverse this decision, and thank you all for your time.
Thank you, Lori, and thank you all. I assume, Madam Chairman, I'm able to go next. And thank you guys for your time and just listening to us in this arena and the opportunity for me to speak today. As Laurie said, I'm Heidi. I get to work with a lot of the Shepherd Pratt rehab services. The pandemic, it really allowed us to take the leap into the virtual world. It's a world that we never would have thought that we were going to get into so quickly. And it was exciting and scary. It presented a large learning curve for us, and it caused us to have a lot of restrictions on our staff and our clients, and our ability to be able to serve the people that we are responsible for. It feels really misguided and doesn't really lead to that innovation and fair access to care that we are speaking about and that we're wanting to have in our communities here. Our teams, we've really looked for various entities to get the financial backings in order to stand up the technology that's been needed to be able to support this new infrastructure. Just to give you some examples and ideas of things that we've been able to do here. The technology that we've been able to secure are tablets. They're cellular enabled. And we've also been able to set up Zoom-free, toll-free numbers for individuals to use. This aids us in that we're able to offset any negative response that a patient may have in joining our telehealth supports, because we're not taking away any of their personal account data. So I'm sure a lot of us here, I don't want to join a group, or I don't want to join my treatment because I don't want to waste my minutes. It's no longer an issue for us now, which has been it was a huge mountain to climb. The technology, it's been able to aid in allowing us to have additional wraparound supports for patients in our care. No-show rates have declined for our providers, like our clinics, primary care practices. We've been able to intercept and intervene in a quicker manner in a lot of our cases with working with our individuals in this arena. Another example that technology led us to is extended social and community interactions. Examples of this was an increase of peer-to-peer driven projects, like a project that Shepherd has advertised, our Art for Justice program, where we were able to bring together individuals from across our entire rehab system to develop the Art for Justice program, where we focus on and largely the individuals that spoke on this, our peers, our patients that we're serving, George Floyd, the Black Lives Matter movement, really that's what spearheaded this. And the individuals wanted to come together, support each other, and talk through what this meant to them and what they wish our community could do and would do in this space. It also led to us joining various partnerships with police forces, where the police join these cross program groups to be able to speak directly with the patients and talk to them about various community initiatives that are going on and work through any challenges that they're experiencing when we're working with police, especially in emergent situations and critical situations that we're so desperately to work through. We're currently experiencing an uptick in COVID-related cases. I'm sure you guys have heard. So we're really hoping to get best efforts here to help wrap around the population that we're serving, get through and work through the staff challenges that we have in order to support the patients that we're serving. And I'm really hopeful that we're able to continue this conversation and talk through this and be able to help those patients that desperately need our care in our communities. So thank you so much for the time today and letting me just share some examples of how this has been so valuable and helpful to us over here in Shepherd Pratt Rehab Arena.
And thank you, Madam Chair. I'm going to close out this panel discussion. Thank you, Madam Chair and Chair Kelly, for your leadership in enacting the telehealth legislation and for convening this briefing today. I'm Ellen Weber. I'm Vice President for Health Initiatives at the Legal Action Center. And the Legal Action Center convenes the Maryland Parity Coalition. We believe that the restrictions violate the intent of the legislation and that they have actually no legal effect until they are promulgated as a regulation under the Maryland Administrative Procedure Act. These reimbursement restrictions have both substantive and procedural concerns. The previous witnesses have described the substantive concerns, and I'd like to focus on the procedural deficiencies. As Assistant Secretary Yee said,
The Department AG doesn't think that these restrictions violate Section 5, but I have to emphasize here that he said absolutely nothing about their failure to comply with the Maryland Administrative Procedure Act. SB 3 and HB 123 allows Maryland Medicaid, and I'm going to quote this because, again, Secretary Yee did not include the exact language, but what it allows Maryland Medicaid to do is to specify in regulations the type of providers that are eligible to receive reimbursement for telehealth services. But the state clearly didn't do that. Maryland Medicaid bypassed the rulemaking procedure, and it has prevented the General Assembly and the public from having a voice in the adoption of regulatory standards. And this is particularly important because the AELR, under the law, has the right to review this policy for consistency with legislative intent and whether it's within the authority of Maryland Medicaid, to hold hearings, and even if necessary, to object to the rule. So what I'd like to do is just spend a minute, if I could, to describe why the BHA and the Medicaid guidance is subject to the rulemaking process. The Medicaid standards, restrictions, and VHA guidance is a regulation. It has a general application to substance use disorder residential and PRP programs and their clients. It has future effect because it's going to determine the reimbursement through at least June 30th, 2023. It was adopted to carry out a law that the Maryland Medicaid Agency administers, and it does not concern just the internal management of the Medicaid program. Maryland courts have made it crystal clear that a regulation that isn't promulgated through publication in the Maryland Register for public notice and comment and submission to the AELR prior to publication has no legal effect. Therefore, the BHA guidance can't be implemented until it's adopted properly. I want to just close by saying that Maryland Medicaid currently has regulations on the books. This is in COMAR 10.09.49.04 that governs the covered services that can be delivered under telehealth. And what this rule does is it changes that standard. And so if it already has a rule that applies to what's covered for telehealth service delivery in regulation, it can't do anything other than modify that rule via the rulemaking process in order to be consistent with the law. And so we urge both the General Assembly and we urge Maryland Medicaid to not implement a rule that doesn't comply with SB 3 and HB 123, and most important here, doesn't comply with the rulemaking process as this state adheres to. Thank you very much.
Thank you. With that, we're going to turn to the people who have their hands up to ask questions. Let me first, though, thank the panel members. I didn't want to interrupt the flow of the conversation. I have nothing to add between members, so it's better for me to let you go ahead. So thank you for understanding that. I'm going to call on Senator Kelly first.
Thank you, Madam Chair. I must say I found this panel very, very helpful and answered a number of questions that have been going around in my head. But one thing that I would like to have someone consider is the impact of the great contraction in mass transit in the Baltimore metropolitan area. That's in the Baltimore City and Baltimore area, county area, at the time when you don't want to keep up significant availability through telehealth. And when for many of the people who need the services on a regular basis, including the young children that would need to be accompanied by a parent or some adult, many of whom are essential workers, it could take half a day and the essential workers couldn't get to work, and they aren't, and people who have been waiting for their unemployment aren't getting that. So they don't really have the material means to travel to do what could have been done much more simply through telehealth. whether they chose telehealth because of its efficacy for their circumstances or because of this sheer necessity, given what else has been cut, including essential transportation for getting somewhere and back without the parent or an adult losing their job and not getting unemployment if in fact the job is lost. So I see a lot of people in a conundrum, and young kids who can't get vaccinated and who in many cases are some of the patients that we're talking about, not able to have the means for reasonable transportation that would allow a parent who's an essential worker to get them there and back and not end up unemployed. So Webster, I'd appreciate your considering these concerns. I think in addition to what we've just heard in terms of legal rulemaking issues that perhaps we haven't followed, all of this needs to be taken into consideration before we actually implement this guideline, which I think is quite unfortunate. Thank you.
Did you have a response to that, please?
Sure, Madam Chair. Madam Chair Kelly, excuse me. Thank you for that question. With respect to the transportation, I will check back with my colleagues and try to get you a more informed response. I need to check both with MDOT as well as our non-emergency Medicaid transportation. If I could ask my colleague, Dr. Jones, to answer your question about child and adolescent respite services, I would be very appreciative.
That would be fine. Dr. Jones?
Thank you. Are you able to hear me?
If I turn up my volume a little bit, I will.
Oh, okay, do I need to talk a little bit louder? Can you hear me better now?
That's fine, thank you.
Thank you. So I don't know if I heard the question specifically about respite in and of itself, but the change to the regulation for respite was done because respite ceases to be respite when respite is for the caregiver. It's to ensure that the caregiver has a respite and has someone who's able to take care of their loved one who needs respite. In this case, we're talking about children. And so through the pandemic, first, and I would say that when the pandemic first hit, we had a very liberal interpretation about what should be provided in a telehealth manner. And we generally said that just basically everything that we were doing pre-COVID will continue in a telehealth manner. We didn't consider whether this was going to be, and there were lots of states who felt differently. There were lots of states that took different positions about different types of behavioral health services. But so that we could ensure that there was a minimal disruption to services, we had a very liberal interpretation about services that could be provided in a telehealth manner. One of those services would be respite services, which by definition, again, are services where you're taking the child out of the environment and you're giving the caregiver an opportunity to actually rest from caretaking. And we strongly believe in, and by the regulations that are therein, you cannot provide 100% respite to the caregiver if they have to in some way supervise the person who's supposed to be getting the respite services. And so that we can truly provide the supports to the caregivers who are providing care for their loved ones, their children who are having a challenging time throughout the course of this pandemic, we felt that it was important to go back to ensuring that respite services were truly respite services for the foreseeable future. So
if I could butt in, I think you're answering a question I did not ask. I didn't talk about respite services. I talked about the fact we've been losing transportation services in large areas of the Baltimore metropolitan area, and that a lot of these people who would need to accompany a child if we don't allow the telehealth modality to continue are essential workers who also aren't there to take the child, and the services aren't there to transport them in a reasonable way. And we also aren't paying them their unemployment. So it was about those sets of circumstances, all of which are impacting on what would happen when a child is in a state of emergency, needs to be seen, and you now don't want to do telehealth.
And
Chair Kelly, I apologize for then if I misunderstood your question. I'll certainly check with our MDOT colleagues on the transportation question, but then to be very clear then, if it's just a child receiving telehealth services, there are no changes. They can receive telehealth services, except for the respite bit that Dr. Jones just talked about.
Well, the child was just one example, but you're cutting out telehealth from everybody at a time when transportation in a major area of the state is in a state of contraction, and people can't get where they need to go for the service in person and get back and still be an essential worker and do their job and take care of their families. Okay, I'll shut up.
Well, and
Chair Kelly, go ahead, please, Dr. Jones, please.
I was just going to say that the overwhelming majority of services will be able to continue to be provided in a telehealth manner. We are only changing the regulations or changing reimbursement for services that are not appropriate to be delivered. So, for example, with regards to the PRP issue, PRP services are designed for persons who have severe and persistent mental illness. The way that things are currently reimbursed at this moment, a severe and persistently mentally ill individual could possibly go up to 6 months without having an individual encounter with their PRP provider under the way that we are currently orchestrated. That is not appropriate for someone who is severely and persistently mentally ill. As a provider, a psychiatrist who has requested for my patients to go into PRP programs, the idea is that they are going to be seen on a regular basis and have benefit from the milieu therapy and the other interactions that people have when they're going on site for services. You can still have the interaction in a one-to-one format from a telehealth perspective. And if someone is decompensating, if someone is showing any sorts of behaviors that show that their illness is coming back or not being very well managed, that can be determined on an individual basis. However, when you are seeing someone consistently only in a group format through tele, there are lots of opportunities, missed opportunities for detecting someone's deterioration in their mental or their psychiatric condition. And that is what we are trying to prevent or ensure does not happen by ensuring that if someone is engaging in PRP services, they can continue to be seen individually through telehealth. They can come on site and be seen individually. They can come on site to have groups, but we won't miss someone's deterioration for their psychiatric condition because they will have someone will actually be seeing them on an individual basis and making sure that their needs are being met.
I'm going to call on Vice Chair Peña-Melnick at this time.
Thank you, Chairman. And I apologize, my video is not on, but my internet is a little stable. So I have a question for Dr. Jones, and I try to make it really simple to see if this is just a yes or no, and I'll follow up depending on your answer. Do you have claims data at each of the different levels of residential treatment? As you know, there are 4 levels depending on the intensity of need and services. They show how much of the client services are being delivered by telehealth. Do you have that claim data?
I believe that we do. Do I have
And
that
if
with me
you-
right now? I do not have that with me at this moment now.
And what does that data show? What does the data show?
The data certainly does show that there is utilization of telehealth in SUD residential programs much more than there was pre-COVID, which obviously makes sense. That's the most of what that data shows from what I can recall of it.
But you don't recall percentages or anything like that, correct?
No, it was not broken down by that.
Will you be so kind, Dr. Jones, and provide to the chairman and the committee that data, if you could provide it, breaking it down to all those 4 levels? We really would appreciate it.
We will get that information to you.
Thank you very much.
You're most welcome.
Thank you. We'll now turn to Delegate Lewis.
Thank you, Madam Chair.
and hopefully you can hear me. Thank you so much. Thank you to the panelists. My question is about the discrepancy or gap between the end date for the emergency order provisions and the start date of a piece of legislation that we passed regarding alcohol and drug use counselors who we've enabled to provide telehealth services. So the governor's emergency order, which ends on August 15th, covered the allowance for alcohol and drug trainees to deliver services via telehealth. And then, which is great. And then this committee in the General Assembly passed a piece of legislation, a very nice piece of legislation. I think the sponsor was particularly awesome person, but passed a nice piece of legislation that makes this change permanent. So it permanently allows alcohol and drug counselors to offer services under supervision, of course, using telehealth. But that bill that we passed doesn't take effect till October 1. So between August 15th and October 1, that's a 45-day gap where alcohol and drug treatment counselor trainees are in a no man's land, where technically they would not be permitted or authorized to give telehealth services. So that's a problem. I'm sure none of us want that. My understanding is the Board of Professional Counselors had convened their own meeting last Friday. They agreed to ask the governor to kindly extend his emergency order regarding alcohol and drug trainee service providers so that there would be no such service gap. And I was told they were preparing a letter. I have a copy of the letter that the Board of Professional Counselors did send to the governor. It's dated last Friday, July 30th. My question for Webster, good to see you, by the way. My question for Webster is, have you seen the letter from the Board of Professional Counselors on this subject? And
yes, Delegate Lewis.
Thank you. So in that case, I'm curious if whether there are any discussions underway or planned to take action to avoid this coverage gap. It's just a 45-day gap that a simple order could probably fix.
The answer is yes, there are discussions. In fact, the executive director of the Board of Professional Counselors texted me a short while ago, and I said, "Hey, I'm in this hearing. We're talking." I think the main issue, I guess, is as I've noted before in the prior section, the administrative grace period ends next week. And at that point, there is a provision in the Health Occupations article that essentially says that the health occupations boards are statutorily independent of the Maryland Department of Health. So we're looking into where there are any legal flexibilities in existing law that permit the Department of Health to expand another health occupation board's scope of practice.
So if I understand, and if I may, Madam Chair, just to clarify, if I understand you, Webster, you're saying that there would be an opening that would allow the Board of Professional Counselors to make a decision about the scope of practice for alcohol and drug treatment counselor trainees?
Again, I would probably need to sit down and actually, figure out exactly what I can say with an attorney general, but my limited understanding right now is that the board could, on its authority, perhaps render a decision or a flexibility. We're exploring from the health department's perspective what statutory authority we have to go into a statutorily independent health occupation board's scope of practice section, and we'll see what options there are. And this is a matter that we are certainly looking into and hitting the law books on.
Well, may I just say that you're going to be, it looks like you're going to be quite busy over the next 7 days fixing the nursing home issue, the PRP issue, and this one as well. So I salute you in advance. Thank you for any help you can give. We don't want anyone to be left without coverage. Thank you, Madam Chair.
Okay, I'm going to remind our members to try very hard to have shorter questions than the answers. We're not really succeeding at that. I understand context needs to be included, but let's try. Senator Augustine, you're next.
Thank you, Madam Chair, and thank you to the panelists and to the department for coming. The first thing that I want to say is Dr. Jones just said that she was changing regulation. I just want to make sure that everybody heard her when she said that, because that is precisely a request that I know that I have made with the Attorney General to assess whether or not these actions are in fact changing regulation, and if they are, that they, as Ms. Weber mentioned, are not, they cannot be enforceable and they should not go forward. And so my question to you, Webster, is given all that you have heard about the surging Delta variant and how that is creating real dangers for the people who are involved in this, and while you're reducing telehealth, given the fact that we have an outstanding situation with regard to an AG opinion on both the larger legislative intent plus the about the matter of regulation, would you consider at least holding back on the implementation of this for an additional 30 days, which gives some more time right now for providers to continue to provide the services that we think that they should, and that we would have clarity before you make these kinds of decisions?
And just to clarify, Senator Augustine, Dr. Jones and the word regulations, she is not an attorney, she is a physician. So we are certainly looking into all possible options right now. As I said earlier in the earlier section, right now we're focused on all of the tremendous work that needs to go into the end of the administrative grace period and the unwinding of COVID-19 flexibilities.
So you didn't answer my question. Will you consider it or will you not?
Again, Senator Augustine, we're focused on the end of the administrative grace period right now. We're trying to get as much work as we can done before the end of next week, and we'll certainly work on other considerations as we're able to go down the punch list.
Thank you, Madam Chair.
Thank you. The good news and the bad news is that as we have this grace period going on, the crisis is going to significantly increase in terms of COVID and the needs, and we're going to be back to where we were. Next, I have Delegate Hill.
Thank you, Madam Chair, and thank you for the panelists. If I had a second question, I would have asked Lori Dole to respond to the PRP comments, but since I don't, I'll stick with the first question. And that is, Webster, I have been listening very carefully in both this section and the last to not only what you've said, but what you haven't said. And I want to make sure that I'm hearing you correctly. Is what you're saying that because the administrative fee in the last segment and the rules about reimbursement for telehealth in this segment were tied to the state of emergency, that with the ending of the state of emergency, the administration has no authority to extend those programs, and the state of vaccinations and cases makes it impossible, even if the administration wanted to, for it to again impose a state of emergency? Is that what you're saying, that your hands are tied, and unless there's legislative action, you have no authority to extend what was done for the past 18 months or so?
Delegate Hill, I think that's certainly an interpretation. With respect to the end of the state of emergency, that's a legal declaration, and it is statutorily prescribed in the public safety article. So we follow the law.
So is that a yes or no? You don't think you have the authority to extend it any further since the state of emergency? So all this conversation is pointless because you're saying you don't have the authority to do anything else. Is that what I'm hearing?
Well, on August 16th, basically, unless we're able to have specific statutory authorities that we can point to for our actions, essentially we are in pre-COVID-19 on a legal perspective.
All right, thank you. Thank you, Madam Chair.
Thank you. Delegate Bagnall.
Thank you, Madam Chair. I just want to quickly recenter the conversation because Deputy Secretary, you've mentioned the administrative grace period and unwinding COVID-19, but the telehealth bill was recognizing an evolution in the delivery of health services, which is why we wanted to study it, which is why we have a report. And this decision, as well as putting our most vulnerable in potential jeopardy and moving providers out of the Medicare Medicaid market, essentially would make that report somewhat moot. So under that context, does the department, as you're making this decision as part of the unwinding of COVID-19, does the department expect to see a decrease in the utilization of services? And if not, how does the department plan to aid in the expansion of services should we lose providers from the Medicare Medicaid market? And what would be the anticipated financial impact of that to the state if we lose providers in order to meet the network adequacy mandates?
Delegate Bagnall, I think I can honestly say with an absolute straight face that I have not seen the future, and I can't tell you what is likely going to happen in the months and the year to come. What I can say is Dr. Jones and our clinical colleagues and my programmatic colleagues are looking at the data, and we hope to make changes as indicated by the COVID-19 situation in Maryland.
Delegate Cullison.
Thank you, Madam Chairman, and I hope that you will indulge me on a little matter. These are questions for Dr. Jones. And the first is, can you clarify how the restrictions that the Behavioral Health Administration is placing on the use of telehealth in intensive outpatient programs that Webster alluded to in his PowerPoint?
There were no restrictions that we put on IOP program. I think what he was speaking to, but no, that we haven't put any restrictions on IOP services. So okay. I think that the 2.1 or no, there's no restrictions on IOP services.
Okay, I wanted to clarify that because that was not clear in the slide. So then
I think that what that one was speaking to was that what we expect is that patients are going to be able to get the same time allotment for services that they were getting pre-COVID. So all of our rules are going back to, so if you were supposed to be getting 9 hours a week of service pre-COVID, during COVID, we allowed for providers to provide lesser amounts of care, but not because that was in the patient's best interest in terms of for their disease process. So what we're saying is that moving forward, we expect our patients to get the same amount of care that they were receiving pre-COVID, whether they are doing it in a telehealth format or whether they're doing it face-to-face.
Okay. So the second question, I promise this is the last one. I met, as you might imagine, I met with many mental health and behavioral health providers during the conversations around this bill. They universally said to me that they believe that this service model was equal to the in-person setting. I'm not saying that I necessarily agree that it's 100% equal all the time, but I am telling you, this is what the providers were saying to me. This is what the providers were saying to the committee when they did their testimony. So what I'm hearing you say, and I'll go one more place, and I was in a meeting, I inserted myself into a meeting with some providers and advocates where all of the providers who were on the meeting, when they learned the intent of HB 123, which was to use this year to figure out whether or not the in-person services were as valuable and effective as the telehealth services, and vice versa. They were very happy to hear that this was a year of study. Those were the providers on the call. What I'm hearing you say is that the VHA has decided now it's not always the same, and in some settings it should not be the primary modality of service, not service, but modality of service. And I question the 50% notion because for the residential services, because if the issue is if you can have telehealth services and they meet the needs of in-person services, you shouldn't be in a residential setting. I'd suggest that that should not be the measurement for appropriateness of placement. That there are other measures that should look at whether or not a person needs the intensity level of service. So if you can help me understand how this appropriateness was decided, it sort of dovetails on the vice chair's question. You have data about how much telehealth was used. Do you have any data that says there were negative outcomes because of the use of telehealth in these residential settings?
Thank you, Delegate Colson. There's a lot there.
I'm sorry.
It's okay. So with regards to how the decision-making process. So we went through every single type of service that the behavioral health authorization authorizes that we allow people to deliver. And there are many, many, many types of services that we allow, over 30. And we looked at each individual one. And we said, which of these services, the delivery of this service in a telehealth format, in which way does not serve best the clients that it is that we're talking about, the clients that use the public behavioral health system for care. And we determined that the overwhelming majority of services that we authorize can be delivered and should continue to be able to be delivered in a telehealth format. However, we identified a very few of the number that we authorized that we said, we're talking about the most severe and the most sick people within our healthcare system, those who are using our PRP services and those who have the disease of addiction so severe that they cannot manage to maintain their sobriety recovery in a home-based environment. And so we looked at those services, and then when we made the determination of which ones we felt we should not continue, we went to our stakeholders. We had meetings with representatives from mental health, substance use disorder, residential programs, and even a legislator with a proposal about what it was that where we were landing and what we were thinking about what was best. And we got their feedback as well. The feedback was that the providers and these were our trusted advisors as well, supported the decision that it is that we made. However, they gave us more information and said, we were looking at even broader restrictions, and they said, no, this is how we're doing this. This is how we're doing that. It would be best if you, are you considering this? Are you considering that issue? And based upon that interaction with our stakeholders and continued conversations that we've had, and because we've been engaging our stakeholders throughout the entirety of the pandemic, we landed where it was that we landed. And so, it was not just the Behavioral Health Administration in a bubble making a decision. We looked at all of our services. We said that most of these services should continue. We talked to our stakeholders, and we decided with their support that these were the services this is where the limitations should be.
But the decisions was based on what? Just professional input, but there's no.
The decision in large part was based upon what was happening in the field. So when you look at PRP programs, for example, PRP programs that are working with our most severe clients, which is what they're designed for, many of those providers had already been going back to doing their groups in person many, many months ago. They were asking us, when can we bring our patients back in? When can we bring our patients back in? Because they were seeing that they were not having the impact and being able to deliver the service as it was designed in terms of what the expected what the expectations of the type of services that should be delivered that was not happening. And so they had been asking us for months to send people, to allow people to come back, even though we never told them that they couldn't meet in the first place. We never said that. We just stressed the importance of making sure that people were following good safety protocols from an infectious diseases perspective. So and then with regards to the residential services, again, the perspective is looking at the person who's using the service. When someone goes into a residential drug treatment program, they're not going there so that they can have all their services provided in a virtual way. They're going there to have interaction. And so what we have done is try to put a floor to say that what a minimum standard of care should be for someone who is receiving PRP services, that they are not going to be able to go and only be seen twice a year by their PRP provider in a face-to-face format, individual face-to-face format, and that they are going to go into a residential rehabilitation program and they're never going to be engaged by the people who actually work at the program in a face-to-face format. Most of our providers who are also doing residential services were not doing 100% tele in the first place because their staff is there to provide service. However, again, we wanted to make sure that there was a floor to ensure, because everyone doesn't do the exact same thing. So if you were going to one program versus another, you have a more high conscientious provider versus another. We wanted to make sure there was a baseline level of care that people could expect to get when they were going for services during this time and for the foreseeable future.
So some of that we'll get from your information around how much was delivered by telehealth. Thank you, Madam Chair. I'll stop now.
Thank you, Delegate Cullison, and for all your work on that bill. You guys did an amazing job. The last question will come from Delegate Lewis-Young.
Thank you, Madam Chair. I have a follow-up access question that I'd like to direct to Webster. Webster, while there's certainly a lot of debate as to whether the COVID pandemic is stabilizing or growing, there really isn't any debate about whether the mental illness pandemic is growing or not. In fact, the data we receive every day reinforces that it's growing exponentially. Mental illness overall, but in particular, substance abuse and suicides. And these tend to be the populations that have the most limited access and may only be able to access treatment through telehealth. So if number of cases is your sole or main decision-making criteria for other forms of program support, why isn't number of cases a significant decision-making criteria for mental illness services?
Delegate Lewis-Young, I think Dr. Jones had briefly touched on this subject, so if I could refer this question to her.
Sure. Again, we are not restricting access to services through the actions that we have taken. The overwhelming majority of our service lines will continue to be able to be utilized in a telehealth format. So if you're talking about someone who doesn't have access to technology, well, if someone doesn't have access to technology and they're in a residential, are you not? Is that not what you're saying? No. I'm sorry. Okay.
I'm talking about someone who doesn't have access to meeting in person and will only access treatment through technology.
So, okay, so the places where, again, where that falls in for us are PRP services, which you can be delivered through telehealth format. So you can have PRP services individually, live, or individually through tele, or you can have them in a group live, if you do a group tele, you can do a group tele, but you can't get reimbursed for that service. but that doesn't stop you from doing it, because most of our providers are actually, there's a certain number of encounters that providers have to have in order for them to be able to bill. So we're saying that the encounters, your billable encounters, are the ones that you cannot do a group tele. But once you have reached your threshold for billable encounters for that particular individual, you're free. I mean, you can do whatever you want to do. You can get, but you just won't be getting reimbursed for that service. But that's not going to stop most providers from doing it if they're truly trying to make sure that they are having regular contact with the people who are under their care. So I don't see how this is going to be a barrier. And then for residential, if you're going into a residential environment, you are comfortable with you have to be comfortable with being around other people, because that's why you're going into a residential environment, as opposed to just staying home and getting your care from a home setting. I'm not sure how that translates as to someone who prefers tele, that they would go into a residential setting and expect to have teleservices.
Thank you. I'm not sure my question was answered, but thank you.
Chair, you need to unmute yourself, please.
Thank you. I keep turning it to block noise that's in the background and then forget to turn it back on. I apologize. And there's the noise. So we'll now turn to Developmental Disabilities Administration, and that will be started with Vice Chairman Penny Melnick, who will present the context, and then we'll turn to Webster Yee and then the panel.
Thank you, Chairman. So Appendix K is a standalone appendix that may be utilized by states during emergency situations to request amendments to approve home and community-based waivers. This has been in Maryland very important for Medicaid, as you will hear, enrollees to get basically the long-term services and supports that they need during COVID-19 crisis. It also, Appendix K is very important because it provides more flexibility to the programs, and the providers will tell you that. So as the administration presents, I like them to address the committee because as of yesterday, August the 5th, Maryland reported 700 new coronavirus cases, as active hospitalization have risen for the 11th consecutive day. So making all these changes, although we're not quite in the emergency we were about a year and a half ago, we're still dealing with COVID, and the numbers, the data is very clear that those numbers are rising. So I like the administration, Madam Chairman, to present to the committee, what they're doing and why the need to change and get rid of these changes, these amendments that have been able to help the provider, especially the most vulnerable, which are people on Medicaid, which are the people that are very poor, that do not have a voice. And all these people that have been today, that the committee held this hearing for, are those people particularly. They're people without a voice, people that need the help and are in worse conditions than they were even before the pandemic started. Thank you, Chairman.
Thank you. Deputy Secretary Yee.
Thank you, Madam Chair. Webster Yee, Assistant Secretary with Maryland Department of Health. I hope everyone takes the opportunity to call me Webster. We remain committed to fully reopening the state as we reemerge from the COVID-19 pandemic and understand that some flexibility is required. The Department of Health is currently engaged with the Maryland Developmental Disabilities Coalition, whose members are the ARC Maryland, Disability Rights Maryland, MAX, the Maryland Developmental Disabilities Council, and People on the Go, to determine a mutually agreeable post-COVID-19 transition pathway so that our focus stays on the health and well-being of Marylanders with developmental disabilities. In July, the department proactively reached out to the DD Coalition, and we're now meeting, I think about our third week now, twice a week with the coalition members in person to understand their concerns and discuss what Appendix K flexibilities the state can and cannot continue. As part of our meeting materials packet, we provided a copy of our meeting schedule with proposed discussion topics. I can also now add that we are now scheduled with meetings through, I think, September 9th. When we have the transition pathway mapped out, we will notify all DD providers and the committees. Last Friday, we issued an initial update to all DD providers, and I believe that letter was distributed last week, shortly before the briefing, as well as provided to all DD providers. We're committed to a thoughtful unwinding of Appendix K that will ensure that Marylanders with developmental disabilities live the lives they choose with the support they need, and that providers have the guidance and assistance needed to resume pre-pandemic services. I should note that we are currently engaged with the DD Coalition on reviewing the Appendix K flexibilities to determine which flexibilities may or may not be needed, which will sunset at a certain point, and which may remain permanent. And so this is a supremely complex topic, given the state of the Developmental Disability Administration's regulations. We sent to the AELR committee, I believe 2 weeks ago now, a request for an emergency set of regulations. And I don't know if Delegate Rosenberg is on, but we would earnestly implore him and other members of the committee to approve those emergency regulations before the end of the administrative grace period next week, so that we're able to continue certain very important billing practices and services through regulations. And with that, I'm happy to take any questions. Vice Chair Penny-Melnick, I think.
Yeah, can you hear me? I like, if I may, before question, if I may ask some of the panelists, like Ms. Howell, to address the committee and give us some context.
Sure. Thank you, Madam Vice Chair Penny-Melnick. My name is Laura Howell. I am the Executive Director of the Maryland Association of Community Services, also known as MACS. And we represent community providers across Maryland who provide about 85% of the supports and services funded by the Developmental Disabilities Administration. And I want to thank you and all members of the committees for including this important issue today in your hearing. The DD community, including families, community providers, and people who use supports, have struggled through this incredibly difficult time, having to take even greater precautions than the general public due to the heightened risk to people with developmental disabilities. And I think a lot of people are unaware of how significant this is. A study of approximately 65 million people published in the New England Journal of Medicine this spring found that having an intellectual disability was, quote, the strongest independent risk factor for presenting with a COVID-19 diagnosis and the strongest independent risk factor other than age for COVID-19 mortality. People with intellectual disabilities were found to be more likely to be admitted to the hospital with COVID-19, 63% versus 29% in the general public, to have higher rates of ICU stay, 14.5% versus 6%, and were more likely to die following a diagnosis of COVID-19, 8.2% versus 3.8%. So for these reasons, the flexibility and resources provided through DDA's Appendix K have been critical to meeting people's needs and keeping people safe and healthy. This hasn't been easy for many reasons. First and foremost, community providers are experiencing the worst workforce shortage in anyone's memory, with vacancy rates that can easily range from 30 to 50%. We absolutely cannot provide services without staff. Vaccine hesitancy, as others have talked about, remains a problem, requiring that we continue safety precautions that others might be able to forego. We also have the added challenge of some people with developmental disabilities struggling to wear a mask in public if needed. Providers are also working to rebuild their transportation services in a way that will maximize safety in vehicles. And people with disabilities and their families vary in their comfort in returning to day programs and supports. Some feel more comfortable in the building that is home to their day program.
Some would prefer to be in the community. Many have jobs. Some prefer virtual supports, and for some, virtual supports don't work. Some want to resume services, and some would prefer to wait. Appendix K has given DD providers flexibilities in how we provide supports and additional funding to address the increased costs we have faced for the last 16 months. There's absolutely no way that we would have been able to meet people's needs without Appendix K in place. And there's absolutely no way that we will be able to provide a smooth transition for the 18,000 Marylanders who use DD services without the Appendix K provisions remaining in place for many months moving forward. I do want to point out the stakeholders were repeatedly told that the Appendix K flexibilities would be in place until 6 months after the federal public health emergency ended. That has created a difficult situation for providers and people with disabilities and families who have relied on that date. And as we look at Appendix K ending, one of the growing concerns, not surprisingly, is the impact of the Delta variant on our ability to fully reopen services. Having said that, I do want to say that we are grateful to Secretary Schrader and his team for their leadership in bringing the DD Coalition to the table to try to develop solutions to this issue. As Assistant Secretary Yee said, we've met several times over the last few weeks. I think we've made progress in putting a plan in place to continue many of the critical flexibilities past the August 15th date. And I do believe that the Secretary wants to support community providers and families and people with disabilities to make this transition as smooth as possible. And we are hopeful that solutions will be put in place to make this happen. And I know that there are two more people who will testify, and you'll hear from a family member and a provider more about the impact of all of this on their lives and the supports that they provide. So I want to thank you for your time, and I'm happy to answer any questions.
Sean, are you there?
I am. I didn't know I was next. Hi, I'm Sean Cross, and thank you to all of you here today. I'm the CEO of the ARC Northern Chesapeake region that serves Harford and Cecil counties. In March 2020, we provided community-based employment and meaningful day supports to over 300 people and residential supports to about 100 people. We had over 400 team members and a waiting list for people wanting supports from our agency in all programs we offer. Our open FTE fluctuated between 8 to 12% prior to COVID. During the pandemic, we were in constant contact with those we support to see what their needs were and how we could best support them during this time. Appendix K offered us the flexibility to continue to serve those we support, but in very different ways. We offered virtual supports that worked for some, but not for all. We offered shortened in-person supports where we could maintain the health and safety of the person and our team members. We remained flexible as the pandemic continued. A lot has changed during this pandemic. Those we support and their families, like many of us, have taken this year to reflect on what their future holds. Just a couple of examples. Some of those who were working prior to the pandemic have chosen to retire or not return to the workforce. Some people who received community day supports Monday through Friday for 6 hours a day are stating that they want to only come back sometimes, spend the day at home, not be out of their home all day. Some are stating that they're still not willing to leave home because they're afraid. Vaccine hesitancy is real for our team members, real for those we support and their families. COVID is still here. In Harford County, we're seeing an uptick from under 1% at the beginning of July to almost 5% today. As we are working very hard to bring as many people back to supports, with that comes risk. Just last week, I had 9 people exposed from a positive person at a community work site. In addition to this month, I've had 5 team members exposed recently from others outside the organization. One of those team members tested positive, and we're still waiting the results for the other. As Laura stated in her statistics, the people we support are more at risk to COVID and its impact on their health. We were told by DDA numerous times and operated under their guidance that Appendix K and all the flexibilities would be in place until June 30th, 2022. So where are we now with those we support 16 months later? We now have 300 team members, down from our 400. And we're actively recruiting for 80 positions to get us back to pre-pandemic levels of support. So that leaves us a 22% open FTE, almost triple to March 2020 numbers. We're working very hard to support everyone, and Appendix K allows us the ability to support everyone in some way. If Appendix K goes away too soon, we will not be able to support as many people as we currently are. We're working very hard to recruit team members. I am competing with companies that pay more and do not require the training and expertise that we need. The bottom line is I cannot provide support services without team members. While I'm grateful for Secretary Schrader and his leadership for bringing the stakeholders together to work through these difficult issues our community is facing, as someone who has to operationalize services, not having something specific is a problem. Appendix K and the flexibilities it offers is needed to be in place moving forward as we continue to support those in services. This pandemic has greatly impacted those we support, their families, and providers of services. And Appendix K is a lifeline as we continue to what I hope is forward out of this pandemic.
Thank you. Next, we'll hear from Laura Hatcher.
Thank you for allowing me to join you today to share my family's experience on the importance of the Medicaid waiver service flexibilities in Appendix K. My name is Laura Hatcher. I'm a small business owner and a mom to a child with disabilities. My 15-year-old son, Simon, has a great sense of humor. He loves to play the drums and watch the Muppets. Simon also has hydrocephalus, cerebral palsy, epilepsy, autism, vision and hearing loss, and a unique genetic disorder. He has complex medical needs, physical and cognitive disabilities, which prevent him from participating in the everyday tasks of life that most of us take for granted, like attending to personal needs, doing schoolwork, spending time with friends, even just getting around, without constant, significant support. Fortunately, after a 9-year wait, Simon was recently able to attain some additional support through a Medicaid waiver. These home and community-based services, which include a direct support professional, were beginning to help Simon work on skills, gain a little bit more independence, and better participate in his community. The waiver services also provided some respite for myself and my husband. By reducing some of our caregiving hours, we were able to focus on growing the small business that we have built together. Until COVID. As soon as the pandemic hit, the services that my son and my family relied on came to an abrupt halt. Our direct support person quit, citing her own health concerns, and our waiver provider told us that they could not find any other staff to support my son. However, thanks to the waiver flexibility provided by Appendix K, our waiver coordinator let us know that a parent could be hired as Simon's staff. We decided to utilize that option. This modest amount of financial compensation for the significant increase in time needed to support Simon helped my family offset a little of the income we lost from being unable to work on our business while caring for our disabled child. A situation that remains unchanged today. The pandemic is not over yet, as the Delta variant has made very clear. The workforce crisis facing caregivers, home healthcare workers, and direct support professionals isn't over either. Caregiving is demanding work for very low pay. Before COVID, it took almost 6 months for us to find staff for Simon, and the problems in finding care that existed before the pandemic have only worsened. As parents, it is incredibly important to us that our son has the care that he needs and deserves. We also need to be able to pay our bills. The flexibility in Appendix K did not make up for the loss of support services, nor did it adequately offset our lost business income, but it has helped my family stay afloat during a crisis that persists to this day. I believe family caregivers should always have the option to become official paid caregivers through Medicaid waivers, as more than a dozen other states have already mandated. This option would help more people with disabilities get the care that they need in their homes and communities. And it would help many families with disabled loved ones stay out of poverty, which is a pervasive problem in our community. Being able to have this option, even in the short term, has helped families like mine weather a crisis. Our families are hardworking Marylanders facing significant challenges. We need more support, not less. I am asking you to refrain from prematurely cutting off a lifeline. Thank you.
Thank you. I see no hands for questions in my panel. And I'm not hearing otherwise, so I'm assuming that there are no questions of members. I'm going to ask a question of Secretary Yee because I'm a little confused by something that was said, and that is, if we've had, in effect, a state of emergency for opioids for 7 years, why is it that we are suddenly so stressed to have to change the rules midstream for these other kinds of services?
Madam Chair, I don't know the answer to that question. All I know is that the state of emergency has ended.
Has it ended for the opioid epidemic?
It has not. Or excuse me, Madam Chair, I don't know the answer to that. Let me check because I believe that the OOCC is now transitioned from the executive order driven to an actual organization in the Maryland Department of Health. So I may have misspoken.
Why don't you get us the answer as broadly as possible to the question with specifics to all of these other smaller pieces, since you seem to be saying to the legislature that the legislature has to give the governor the authority to undo the mess that seems to be being made. And yet 7 years for the opioid crisis authority seems to not make sense in that context.
Madam Chair, to be very clear, I did not at any time make that statement. All I'm saying is that the governor announced the end of the state of emergency for COVID-19 with a 45-day administrative grace period.
My understanding was you said that he didn't have the authority to extend it. Did I misunderstand what you said?
I did not say that the governor said that he did not have the authority to extend it. I apologize if I misspoke.
Well, I don't know that you misspoke. I might have misheard. But the question really is, if this seems to be a self-created crisis for all these providers, why don't we uncreate the self-created process? And I don't know if it is or not. So I look forward to hearing the answer to that, or seeing the answer in writing, not hearing. We don't expect to have another briefing until some regularly scheduled one in September. So with that, I thank everybody for being here. I really appreciate your helping us try to come to some solutions for serious problems from many of our most, I see 2 questions now. All right, I'm going to go back and allow those people to ask questions. I'm not sure why I didn't see them. I see Delegate Banderi. I think that I'm told that also Delegate Bagnall has a question, but I don't see that hand up. Delegate Banderi, I'm going to recognize you.
Thank you, Madam Chair. This question is to Assistant Secretary Webster. Talking to area hospital in Baltimore County, the surge in COVID-19 cases driven by all these variants, staffing levels at hospital across the state remain a concern. And that is the same in my county as well. We need a lot of nurses. We know that they're burned out. And can you share if our department doing something or any strategies to mitigate these issues, and any suggestions we as a legislator can do in the upcoming session? Is there any pipeline of staff, or can you comment on the staffing situation?
I'm sorry, Delegate Bhandari, that's a little bit of a broad question. We are working very closely with the Maryland Hospital Association and the Maryland Board of Nurses, the three major nursing home associations on staffing. We've sent over 30 temporary staffers to the Maryland Board of Nursing, and at this point, they represent, and from the metrics we see, that they have a pretty minimum backlog. The main request from us now to the hospitals and to the nursing homes is that they get their employees, of which there are a decent number of them, to submit a renewal application as soon as possible. Like I said, the administrative grace period ends next week. There are still quite a number of individuals who have not submitted renewal applications for their licenses. And we are encouraging them to submit them as quickly as possible so that we can work to get with the board to get them renewed as quickly as possible. And we've made that request on numerous occasions. The board has sent numerous emails to the individual nurses, and we've been working very closely with the hospital association and the nursing associations. And they've been bugging the heck out of their members too.
Thank you.
Delegate Bagnall.
Thank you, Madam Chair, and sorry for the confusion. I don't know if Ms. Howell is still in the call, but I think this is a question for her because there seems to be some disparity between the guidance that we're getting from the health department, which is around the end of the state of emergency in Maryland, versus the guidance that was provided that identified 6 months after the federal emergency ended. So I was wondering, Ms. Howell, if you could just let this committee know how you were notified about that timeline. Was that from the department? Was that, in statute, so that we have a better understanding of where that timeline is, and maybe we can enclose that discrepancy?
Thank you, Delegate Bagnall. So the as Ms. Cross said, the Developmental Disabilities Administration did repeatedly say in writing and verbally that Appendix K would end 6 months after the federal public health emergency, and that's documented in many places over time. There are some places in Appendix K where it does tie the authority for the flexibility does seem to tie to the Secretary's authority, which we've been told ends with the state emergency. So there are some items that tie to the state health emergency, but a number of items that it appears the department has the flexibility to extend. As Webster said, they are doing some things to try and make sure that they have the legal authority to back that up, like emergency regulations for one or two specific items that are very important. So I think that our issue has a lot of complexity to it in terms of the timeline. The provider community is still waiting to be told officially what that timeline will be, and I know they're anxious for that. So I just want to be clear, because there are probably 4 answers to the question you asked about what's been communicated, when it's been communicated, and kind of where we are at the moment. So did that answer your question?
It did, thank you. If you would be so kind, if you could share that, any of that communication with this committee, I think it would help give us some context. Thank you very much. Thank you, Madam Chair.
Thank you. And with that, I want to thank everybody for joining this committee briefing. Panelists, we do appreciate your taking the time to present to our committee. Have a great weekend, everybody, and this meeting is adjourned.